Good evening, and welcome to the third annual William C. Steubing Memorial Lecture. I am Professor Matthew Liao, Director of the Center for Bioethics at New York University's School of Global Public Health. Along with our Dean, Dr. Cheryl Hilton, and our co-hosts, the Greenwald Foundation, I am privileged to welcome you tonight to what we know will be an illuminating lecture by Professor Keith Whaley, the Henry Putnam University Professor of History and Public Affairs at Princeton University. In this extraordinary year, as our nation battles the twin epidemics of both the coronavirus pandemic and structural racism, Professor Whaley's provocative talk could not be more timely. He will challenge us to consider whose pain matters and reflect on race, social justice, and revealed inequalities exposed by COVID-19. To get us started, it's now my pleasure to welcome the chair of the board of the Greenwald Foundation, Dr. James A. Tolsky. Dr. Tolsky is the department chair of psychosocial oncology and palliative care at Dana-Farber Cancer Institute, as well as division chief of palliative medicine at Brigham and Women's Hospital. Dr. Tolsky is also a professor of medicine and co-director of the Center for Palliative Care at Harvard Medical School. Please join me in a warm NYU welcome to Dr. James Tolsky.
Thank you so much, Professor Liao, and good evening. I'm delighted also to welcome all of you to the William C. Steubing Memorial Lecture. The Greenwald Foundation is the leading US funder of scholarship in bioethics, and our vision is to make bioethics integral to decisions in healthcare, policy, and research. I would also like to express our gratitude to the NYU School of Global Public Health and Dean Hilton, as well as to the NYU Center for Bioethics and Professor Liao for helping us to host this event. This lecture series is named after William Steubing, the founding president of the Greenwald Foundation, who served for more than 20 years in that role and who sadly passed away 5 years ago. During his tenure, Bill was the face of the Greenwald Foundation, and under his leadership, the foundation grew to its current prominence in bioethics. Bill was a remarkable and deeply unique individual. He had a wonderful blend of contradictory qualities. On the one hand, his taste was impeccable and quite conservative. As I read a New York Times article yesterday on Savile Row tailors, I thought of him walking around his favorite London Mayfair neighborhood. On the other hand, he was a radical. He devoured edgy ideas, was willing to take risks, and as a funder, was quick to support controversial work from which others shied away. Under his oversight, the Greenwald Foundation supported research on such topics as organ transplantation from non-heart-beating donors, reproductive ethics, the influence of big pharma, and genetic engineering. Bill was intensely curious and loved to find connections between art and medicine or theology and science. He was kind and generous. And more than anything else, he loved witty, smart, and thought-provoking dialogue. Bill appreciated that what bioethics needed more than anything else was a strong pipeline of talent. He oversaw the creation of an interdisciplinary bioethics fellowship program at Johns Hopkins in Georgetown, as well as the Greenwald Faculty Scholars, a program that began at UCSF under the leadership of Bernard Lowe, our president emeritus, and remains our flagship investment. The graduates of both these programs have become leaders in academic centers throughout the country and are among the most important voices in bioethics deliberation. The Greenwald Foundation's hope for the William Steubing Memorial Lecture is to create a moment where members of the New York community, and now with the benefit of Zoom, the entire world, can come together to learn about current, complex, and important topics in bioethics, gain new insights, and broaden our public dialogue. We hope to model and promote vigorous and civil discourse on bioethics issues that might otherwise escape the public eye. Bill was committed to civility in public debate, something I'm sure we can all agree is sorely needed. We miss Bill tremendously. We are joined today by his husband and life partner, Ron Thomas, and a number of his friends and family. We look forward to continuing this fitting tribute to his memory. And I'm now privileged to ask Michelle Groman, the president and CEO of the Greenwell Foundation, to introduce our speaker.
Thank you, James. Let me add my welcome to this year's William C. Steubing Memorial Lecture, and thanks to the NYU School of Global Health and Center for Bioethics for partnering with the Greenwell Foundation for this event. We usually hold this lecture at NYU's beautiful Washington Square campus. I wish we could all be there now for a reception and enjoying each other's company. But at the same time, I'm glad that this webinar is bringing more people together from all over the country to talk about such a timely and profound set of issues. Before I introduce this year's lecturer, I have a few quick housekeeping notes. First, this event is closed captioned and will be recorded for those of you who are unable to join this evening. Second, we encourage audience participation. If you have a question, submit it via the Q&A box. I will pose a selection of these questions and some that you submitted in advance following the conclusion of the lecture. It is now my honor to introduce our speaker, Professor Keith Wailoo. Professor Wailoo is the Henry Putnam University Professor of History and Public Affairs at Princeton University, current president of the American Association for the History of Medicine, and an elected member of the National Academy of Medicine. His research focuses on the ways in which politics, identity, ethnicity, and gender affect health and medicine in society. An award-winning author, his most recent book is Pain, A Political History, and his next book, Pushing Cool, Big Tobacco, Racial Marketing, and the Untold Story of the Menthol Cigarette, will be out next year. I have come to know Professor Wailoo over the past 5 years as a member of our Greenwell Faculty Scholars Program Committee. One thing that struck me about Professor Wailoo right away is how people hang on his every word. You can always count on him to say something thoughtful and refreshing. He brings so much dimension and perspective that he leaves you wondering how you could fully have considered the issue at hand without it. Professor Wailoo, I can think of no one better to present this year's Steubing Memorial Lecture and bring bioethics into conversation with the concurrent national crises of COVID-19, systemic racism, and racial health disparities. Welcome.
I want to start by thanking you for the opportunity, for the gracious introduction, but also the opportunity to present at this year's William C. Steubing Memorial Lecture. We're, of course, isolated, and in some ways, this is a highly unusual format. That is to say, we are separated and yet we are together. I'm honored that we're able to come together, albeit remotely, to reflect on Bill Steubing's work, promoting ethics in history, in medicine and society, and to advance his and the Greenwell Foundation's extraordinary work and legacy. I took this as an opportunity to reflect, to take a look at the world today, COVID-19, protests for Black lives, the multiple crises that seem to surround us in terms of public leadership, and to try to look through these events to ponder the rich and varied language of ethics and how that language may illuminate our current moment and perhaps lead a path forward. I'll argue that, there's ethics questions that are not just beneath the surface, but right there in public view for all of us to grapple with, often in the realm of virtue ethics or relational ethics. They're everywhere in my work and all around us. Ethics, of course, is not a topic that's owned by any single group, and it's ever present in the challenges that we face. Nor is bioethics separate from the broader work and questions in ethics. Whether in history or in medicine or in my work in public affairs, I've long been committed to thinking critically about and using the language of justice, rights, and wrongs, and principles, and looking closely at the principles underlying our actions in the scholarship that I pursue. And this ethics perspective, as I said, is ingrained in my approach to history, particularly in my writing on pandemics, and as Michelle just recently pointed out, my work on pain. Today, what I'd like to do is to offer some reflections both on pandemics and pain, some reflections on the role of compassion in American culture, medicine, and society, the place of what I call intersubjective understanding in everyday clinical encounters, and also in public policy. Today, my somewhat meandering reflections will revolve around three questions, some of which are captured by this shocking and tragic chart. One question is, what has been revealed in this pandemic year, as in other pandemic years in the past? The second is, how do these revelations speak to the question that I pose as a title, whose pain matters, and our social inequalities? And a third question that I'd like to explore is, what does this mean for ethics, particularly for the values of truth, our relations with one another that are rooted in ethics, and the goal of building a society informed by foundational principles such as those of justice. The images that you'll see here, as well as the headlines from March and from October, illuminate just some of the ways in which ethics have come to the forefront in navigating the medical challenges of COVID-19, challenges of triage and the rationing of care. It's a really heartbreaking story of close to 250,000 tragic deaths in the course of this pandemic, over 11 million cases in the United States. It has been a heartbreaking year to watch what had once been called the best healthcare system in the world struggle to find, to see and sort of struggle with the challenges of this. It's been hard to actually see the costs accumulating of what has been an impoverished public health system struggling under the weight of this pandemic. It's also been difficult for many of us to witness the failures of leadership in this ongoing crisis, whether on the simplest interventions like PPE and N95 masks, and the more complex questions of bringing the nation together, or contact tracing, or simple messaging and coordination and agenda setting. Today's headlines, literally today's headlines, remind us once again of the revealed inequalities of the pandemic. Pandemics have always been revealers and also accentuators of inequalities. Today's headlines speak of the higher hospitalization rates for Latinx, American Indian, African American populations at 4 times the rate of white groups. It speaks of the intersecting reasons for this state of affairs, the higher positivity rates among Blacks, Latinos, and American Indians as compared to whites because of jobs held in the food service sector, work in home healthcare, work in non-remote settings, where work, and also work deemed to be essential, such as meatpacking plants, and also people who return from those work environments to live in multi-generational households or who live in densely populated communities where social distancing is more difficult. An intersecting set of factors that shape these disparities. Now, some forms of pain have attracted a great deal of attention during this crisis, such as the vulnerabilities of the elderly, figuring prominently in our public discussion in our politics. Yet others are somewhat less prevalent. For instance, the case of meatpacking workers, meat plant workers across the country, largely, not exclusively in the Midwest, or the crisis in Navajo nations. And then also a significant point of focus has been these kinds of disparities in states like Wisconsin, where the recent data from last month suggests that in a state where African Americans make up 6.1% of the population, they account for 8.8% of the cases, but tragically 17.7% of the deaths. These kinds of disparities in work, location, home setting, as well as where you happen to live in the United States, these disparities raise profound ethical questions. If essential health workers, for instance, should be prioritized for N95 masks, if essential health workers should be prioritized for those masks and protective equipment, wouldn't a society built on foundations of ethics provide these same protections to other essential workers, as well as significant safeguards for those who suffer for the greater good by preparing the foods that sustain us? Does the category essential non-remote worker, for instance, warrant prioritization not just for PPE, but also for vaccines? There are a set of underlying principles at stake here, having to do with people who sacrifice and sacrifice for the greater good, and whether society owes them more than society currently has been delivering. One of the ethical challenges rippling across this pandemic year and carrying into next year is, of course, the question of how to distribute resources equitably. Who has the greatest need? Whose pain and sacrifice should be prioritized? I've spent a great deal of time thinking in my work about pain as understood, experienced by patients, and also how we prioritize relief, how we navigate the difficult topics in healthcare, and how the way we navigate those topics relate to broader cultural and political and ethical debates in society. Some of it is captured, the tensions about how to navigate relief are captured by this humorous cartoon from the New Yorker in 2000, where the physician stands over the patient's bedside and says, "We can give you enough medication to alleviate the pain, but not enough to make it fun." So who's to decide where the line between the righteous, compassionate alleviation of pain and the production of unwarranted pleasure exists? As it turns out, in the book that I wrote, Pain, A Political History, these medical issues have often been inflamed by and certainly informed by broader cultural political debates about the role of compassion in medical care and society, and also intersect with really deep questions having to do with overindulgence, liberalism, and perhaps surprisingly, debates having to do with conservatism and the welfare state. In other words, the debates I found that shaped that doctor's decision about how aggressively, how compassionately, or how skeptically to regard somebody's pain related deeply, intimately to broader political and cultural discussions. Political judgments informed and filtered into the language of patients, of doctors at the bedside. And this could be seen, for instance, in the late 1970s, when a pain specialist named S.F. Brenna in Atlanta wrote a book called Chronic Pain, in which he said that chronic pain is often a conditioned socioeconomic disease, that society had gone too far in granting monetary compensation for escape from work via pain complaints. Here you see echoes, very powerful echoes of a kind of conservative concern about learned helplessness, people who were out to get something for nothing, and their pain was really just the vehicle for them to gain these, to achieve these ill-gotten gains. So learned helplessness on the one hand, or compassion on the other. It turns out that the responses of society to illness reveal underlying ideological and moral commitments and lays bare a world in which that's often unarticulated principles are at work. Principles of compassion and principles of deep skepticism about human nature. In the work that I've done in the history of pain, the previous book I wrote, Dying in the City of the Blues, focused on sickle cell disease and how questions of race were often refracted and informed physicians' judgments. So much so that an image on the front cover of the book comes from a 1993 article. The caption underneath the image was, "Before you can get past the agony, you have to convince a doctor that it's real." So I've been long thinking about the sort of cultural politics of pain, what you might call the micropolitics of pain, how doctors and healthcare providers regard people in pain and what degree of relief they provide, but also the macro politics of pain, how society organizes its disability system, how our public policy reflects these different kinds of ideologies. Now, I'll turn for a little while to talk about the kinds of pain that are revealed in pandemics. These questions of how to measure suffering and what to do about it are not new. The idea that pandemics reveal vulnerabilities and suffering go back into the history of pandemics. Mortality trends in pandemics always revealed social inequalities, and this was true in the case of 1665 London and the bubonic plague, where Daniel Defoe observed that the infection kept chiefly in the out parishes, which being very populous and fuller, alas, of poor, the distemper found more to prey upon than in the city. Here, the suburbs, the out parishes, were the place where the poor resided. In the cholera epidemics in the 1830s and 1840s in New York City, as well as the 1860s epidemics, for example, there were fierce debates about the wisdom of closing ports, stopping commerce, and those who insisted on allowing, and there were those who insisted on allowing the traffic in goods to continue regardless of the toll. And there were those who argued that in the name of preventing suffering, that yes, the economy should be closed for a period. New York City, perhaps not surprisingly, based on what we recently experienced, was particularly hit hard in the first wave, because after all, even then it was a national center for international travel and commerce. And then as now, there was blame. Blame at the time fell disproportionately on African Americans, but also on the Irish Catholic poor in the Five Points neighborhood, as well as Black citizens of the city. As one commentator said, people inhabiting the most populous and central portions of the city. This is also true in the yellow fever epidemics, pictured here below in Memphis, Tennessee in the 1880s. So our revealed inequalities, go back for a second, our revealed inequalities really come in the course of epidemics throughout history. They've always revealed what you might call relational crises. But in raising questions of contagion, you might say that the coronavirus pandemic, like the influenza pandemic, and to some extent cholera and yellow fever, also highlights particular kinds of crises of connectedness that are amenable to blame, problems that you might call questions of relational ethics. Our revealed inequalities today take different forms. They're systemic. They are mirror social institutions of our time, nursing homes, detention centers, prisons, meatpacking plants, and so on. The experience of the flu pandemic bears perhaps the closest resemblance to the current coronavirus. Here, the deaths in the US over a course of about a 15-month period of devastation climbed to nearly 700,000, with worldwide deaths in the tens of millions. Here too, about 100 years ago, were controversies, as today, about mask wearing, and which you might think of, both in retrospect and today, as a study in interpersonal ethics or relational ethics. That is to say, what kinds of principles should guide our personal interactions and care with respect to others, especially given the concern about the transmissibility and the contagion that comes from breath, from breathing. Then as now, there were protests about cities passing mask ordinances, such as these protests covered in the newspaper in San Francisco in January 1919. And then as now, there were police enforcement mandates, as in you see here in Denver, Colorado. There were examples also of masks really inflaming ideological divides. Then as now, you might say the debate about mask wearing could be seen as a study in the distrust of government, but also a study in interpersonal ethics. Denver, police enforcing mask orders. Seattle, however, giving rise to a protest voiced over the gauze mask rule. And the subheading, the subtitle of this article is particularly revealing: some Pacific Coast cities becoming restive under orders of health department relative to the so-called epidemic. That is to say, even a doubt about whether the epidemic is real and whether public health authorities should be trusted. The politics of epidemics and disease have also inflamed racialized blame, fear, and security then as now. Take, for example, this newspaper cartoon pulled from the Atlanta Journal and Constitution circa 1910, not focused on not influenza, which would come about 10 years later, but tuberculosis. Here you see pictured the perception of the threat that's posed to the home flying the flag called average white home, in which you see the average white home, which is threatened by contagious disease carried by the domestic servant, the maid, whose flight, along with other vectors of contagion from her home of contagious disease and filth, over the walls that were intended to safeguard the home through sanitary precautions, screens, pure water, and medical science, have been violated. Then as now, whether it's the story of Jews who were blamed for the plague in medieval Europe, or the Black domestic worker blamed for bringing tuberculosis to the average white home, epidemics have always fomented these kinds of virulent, and I use that metaphor advisedly, ideas. As William Faulkner once wrote, "The past is never dead, it's not even past," or Mark Twain's often commented phrase comes to mind: history doesn't repeat itself, but it does rhyme. From masks to building defenses to blame, what I hope to make clear in what follows is that ethics has everything to do with these images, and that the challenges of our time are about surfacing the ethical concern and reminding ourselves of the fundamental principles of the questions of virtue, the questions of relational ethics, and also how we should apply these values in shaping a healthier and better society. While in all of these discussions, for instance, the discussions about masks, you do not see often explicitly used the language of ethics. For example, I would argue that they're always there, perhaps submerged, often muddled. In one aspect, if one aspect of ethics is concerned with truth, certainly our public discourse in the pandemic has been severely challenged on this question of truth and lying. So one of the challenges of ethics is simply to remind ourselves of basic truths and why truths matter. If ethics is concerned with normative prescriptions of what is good and moral, this also has been very, very much part of our mandates and our debates about masking. And if ethics has also had an applied dimension, this too has been quite evident in our public discussions. Here you see, for instance, a prominent image from April of an anti-mask protester facing off against a masked healthcare worker. One way to think about ethics is that we need to make ethics more central in these debates and conversations. But I would argue that another way to think about ethics is that ethics are, in fact, already central, graphic, vital, and poignant, and that this, too, has been revealed in this, our plague year, like no other year before. For example, let me spend a little bit more time pondering masks, which, to be clear, have been highly politicized, but raise a profound ethical challenge for us. I've already mentioned the ethical challenge of whether people who are essential workers, not just health workers, ought to be first in line for N95 masks. But there are deep echoes of past pandemics in some of these debates. I don't think it's too much to say that a social ethic, the problem of interpersonal and relational ethics, emerges precisely in this space. Masks are about respect that we owe for one another, but for some skeptics of masks, masks have become understood as muzzles, as constraints on the ability to breathe. And so it is that institutions like the Mayo Clinic health systems back in July, when a lot of these perverse theories about the fact that masks were dubious interventions because they constrain breath and they compel people to breathe in their own CO2 that would result in them dying from asphyxiation. And it's these theories that gained traction in July and to some extent are still around today that prompted institutions like Mayo to remind people of the myths of masks and the reality. Myth: wearing a mask will increase the amount of carbon dioxide I breathe and will make me sick. Reality: there is no risk of hypoxia, which is lower oxygen levels in healthy adults. Carbon dioxide will freely diffuse through your mask as you breathe. Now, I realize that for those, so on the one hand, for others, wearing a mask is part of an ethic of social responsibility, a responsibility to safeguard others for little or no personal inconvenience and harm, and also in the process safeguarding yourself. It's the closest thing we have to a vaccine before a vaccine is available. So here you have a discussion, a debate about what masks are about. It's hard to take the skeptics seriously, I know, but if we do, at least for a moment, you begin to see a mindset emerge that is worth considering, buried in these virulent and viral debates that are really fundamentally about relational ethics questions. So this leads me to reflect on what I mean by, not what I mean by, to kind of delve more deeply into masks as a problem in relational ethics. On the one hand, there is the tension between truth, as in consensus opinions derived from empirical observation, and then fictions that are rooted in experience, as in, yes, it is a little bit harder to breathe with a mask on, but extrapolated into a statement that therefore masks are dangerous, and therefore, taking this concept awry, that the imposition of a mask is a threat to my ability to breathe and to my very health and life. This is the argument that was marshaled against normative prescriptions to wear masks and helped to legitimize the idea that mandates are not only an infringement on rights, but dangerous constraints on breathing. Laws on masks are thus seen, thus you might say that they're in the realm of applied ethics. They enshrine certain values of interpersonal responsibility into law and public policy. Now, to be sure, there are huge variations in how this has worked. There are confusions, there are outright fabrications about masks, but the underlying ethical questions have been there and have been surfaced. There is, by and large, an allegiance to consensus, truth about how viruses move through material and air, normative pronouncements, and applications in the real world. Now, there is a fundamental irony here that connects, that sheds some light on grievance and race and politics in the year 2020. Because after all, the debate about masks emerged in a year when we ask not just whose pain matters, but in some ways, whose breathing matters. Watching the anti-mask discussion, one sees a strong air of grievance, anti-government grievance, but also what might be called white grievance. And there is a deep racial irony here about whose breathing matters. Of course, white grievance has predominated in our culture and the politics for 4 years. And I should point out that this is a small rally in Utah. The gentleman with the cap wears a sign that says, "Fear of COVID does not trump my right to not breathe my own CO2. This has been deemed to be a claim lacking in evidence. As I said, of course, white grievance has predominated in our culture and politics for the past 4 years or more. Perversely, this idea of masks as a deadly constraint on breath unfolded at precisely the time that protesters worldwide were marching in protest against a Minneapolis policeman who held his knee on the neck of George Floyd for more than 8 minutes, which constrained his breath, a choking that is both real and deadly, not imagined and not speculative, and has been repeated all too often. So the anti-maskers then are asking whose breathing matters. And they are in some ways repurposing the I can't breathe protest to try to draw attention to their own grievance. I'll come back to this deep irony over whose pain, whose breathing matters, and what it reveals about the deep disparities between Black protest and white protest or white grievance later on. I'd like to say one other thing about other revealed inequalities in this, our pandemic year. As of last week, there were 500 cases of COVID-19 among detainees in immigration centers in Georgia alone. A great deal of attention has focused on university clusters, 11,000 in Georgia, but very little on the roughly 4,000 in Georgia in its 30 prisons and detention centers. This detention center, the Stewart Detention Center, is located in Southwest Georgia. It's the site of 500 COVID cases. It's the site of 500 COVID cases, that's right, in just the detention centers and 4,000 across penal institutions. Stewart County, Georgia, where the Stewart Detentional Center is located, has 6,000 citizens. 70% of those in the county are African American, 30% white, very, very tiny Native American and Latinx populations. The detention center itself is one of the largest and busiest in the nations, with 20,000 detainees. And early on, there was a concern that these detention centers are part of a cruel logic, not just of the detention of undocumented immigrants enacted and carried out in the Trump administration, But there's an irony here, which is that Stewart County depends heavily on the detention center for jobs and revenue. This is also part of the cruel logic of incarceration, where the economic welfare of a town that is itself quite poor and majority African American, a county, depends heavily on this detention center for revenue. Early on in the debate, it was clear that these detention centers would be problems in the spiraling cases associated with COVID-19. They were, as one author said, like petri dishes for the virus. One advocate for one detained man held at the Stewart Detention Center raised an issue that expresses in a vernacular language a moral and ethical quandary, which is, she said, coming into the country without authorization is one thing, but losing your life over this virus is completely different. And what you see here is a question about the nature of punishment and how punishments under certain circumstances can far exceed the crime. However, the logic of detention under the Trump administration particularly was driven by a different kind of logic. And you might say it's in the annals of pain, it's a story of the intention of the intent to inflict pain in order to send a message, to others who might come to this country that this would be your fate. Now, early on in the debate about the ethics of prisons in the age of COVID-19, the Bureau of Prisons did initiate the process of releasing some inmates in April and into May, but not in detention centers. I should point out that the detention center story is part of a larger logic in which you might say the logic of inflicting pain on others predominated. I should point out that just a few days ago, the journal Pediatrics published a piece titled "Treatment of Migrant Children on U.S. Southern Border is Torture." And what they essentially did was draw upon references to the United Nations Convention Against Torture, and argue that what we're witnessing here is more than merely abuse, but it hinges on the intentional inflicting of pain as well as professional conduct. Quoting from the UN Convention Against Torture, any act by which severe pain or suffering, whether physical or mental, is intentionally inflicted on a person for such purpose as obtaining for him a third person information or confession, punishing him for an act he or a third person has committed or is suspecting of having committed, etc., when such pain or suffering is inflicted by and at the instigation of or with the consent or acquiescence of a public official, is considered to be torture. Not surprising, given what I've described about Stewart and the Petri dish effect. In late May, a Guatemalan man named Santiago Batten Oslash, a father of three who was being kept in the facility while awaiting deportation, 34 years old, from Guatemala, died. He had been arrested in Marietta, Georgia on charges related to driving under the influence, a conviction. A second death came in August of a 70-year-old Costa Rican man named Jose Guillen Vega, who died of cardiopulmonary arrest secondary to complications of the coronavirus. A third case announced in September was of a 61-year-old Mexican national, Cipriano Chavez Alvarez, who also died from COVID. Many of them had also diabetes as a complicating factor, and ICE released press releases in each instance mentioning the violations as that these men were being incarcerated and detained and ultimately removed from the United States for DUI, cocaine, as well as sexual assault. So I would be remiss if I didn't mention that these are also revealed inequalities of COVID-19, which intersect with the carceral logic in Stewart, Georgia. The situation in Stewart raises so many concerns: death while in captivity, in a nation that has shunned paths to citizenship in favor of a carceral logic premised on the infliction of pain as a lesson to others not to come here, in a poor county in Southwest Georgia that depends on the logic of the prison as a means of revenue, and that has been one among many disproportionately burdened by COVID-19. It's a majority Black county. I should remind you, it swung Georgia. It helped to swing Georgia for Joe Biden just a few weeks ago. It would take an entire second lecture to unpack the moral and ethical issues revealed by such cases. I'd invite your suggestions for how to proceed in discussing this case. Let me try to broaden and bring my observations on this pandemic year and the ethical issues that have been revealed towards a conclusion by returning to the question of the reflecting on COVID-19, not just COVID-19, but the last 4 years in ethics. You might say, just considering the current outgoing, not fast enough, obviously, administration, the questions of cruelty, the infliction of pain, family separation, the callous disregard for the mounting death toll, mask skepticism, and just outright lying. One way to think about our last 4 years, aside from trauma, chaos, and lying, you might use the term unethical, which has often been used to think about the lack or deficiencies in ethics. But I would argue that this is only partly right. If normative ethics has often been defined as ethical action, then in many ways, the last 4 years has been a lesson of misguided, unethical action, such as when the current president threatens to withhold vaccines from the New York State governor to punish him and the people of the state for the governor's criticism. But I think it's also helpful and important to see these behaviors in another way, akin to understanding mask skeptics, as the consequence of what you might call an ego-driven ethics, in which overblown and skewed ideas of loyalty and obedience, commitments derived from self-aggrandizement and profound self-centeredness, out of which stem behaviors such as lying, and the public fascination with lying, and a profound debate about the limits of deceit and questions of accountability, which we've all had to grapple with in these last 4 years. There is a kind of a sense that, there is a skewed ethical perspective at stake over the last 4 years and in our moment. There's also the negative lessons of relational ethics, the casual cruelty, the pleasure in the destruction of others, not only distant others, but also those deemed not sufficiently loyal. So, this is kind of like a negative lesson on virtue ethics that can be distorted through the lens of narcissism. My point is that the last few years, and particularly this year in COVID-19, have revealed a great deal about ethics by these distortions of principles like loyalty. In many realms, it's been 4 years of going back to basics, of going back to basic civic lessons that we thought were well understood and deeply internalized and turned out not to be the case. So, for instance, do laws matter? Does truth matter? Does ethics matter? Do lives matter? And it's made us restate foundational principles. Yes, lives matter and Black lives matter. The president's threat to withhold vaccines is not about loyalty and obedience, but it is, in fact, about undue punishment, withholding a life-preserving thing of value to win favor. You might say it's part of the ethics of the shakedown. Now, again, ethics, therefore, has not been absent from our conversation. Ethics has not been so much thrown out as thrown into our faces this year. It reminds me, this moment, of an essay by Stephen Toulmin from 1982 called How Medicine Saved the Life of Ethics. Now, I'm not arguing that the last 4 years has saved the life of ethics, but it certainly has reminded us of some foundational concerns in ethics. The ethics questions in this era have been relentless and profound, and in a sense, a reminder of the importance of breathing life into basic principles. As Stephen Toulmin wrote, the central importance of case morality is what he was writing about, and problems in applied ethics were breathing life into what had been a fairly morbid field of ethics. He wrote, defined in purely general terms, such ethical categories as cruelty and kindness, laziness and conscientiousness have a certain abstract, truistical, or self-evident or obvious quality. Before they can acquire any specific relevance, we have to identify some actual person or piece of conduct, or as kind or cruel, conscientious or lazy, and there is often disagreement about that preliminary step. So I would say that this, in some ways, is the story not just of the 4 years, but in some ways segues into the story of our recent election. Because in some ways, I would say that, the grand debate that we witnessed and voted on over the last 2 weeks ago now was not just about, 2 individuals or the administration. What has been remarkable about this last year and these years is not only to see white grievance in all of its forms, which has long played a role in public policy, but what might be called and what might be termed narcissistic white grievance, channeling and feeding off of a president and stoking a discourse that has moved from losing our way of life to my rights are under threat to my breathing is under threat. It's a case study, I would say, of a nation being kind of subjugated to psychological egoism. That is the notion that people are fundamentally motivated, and we have a kind of a leader of the country who not only believes but acts as if people are fundamentally motivated and motivatable by self-interest and selfishness, and thus can be mobilized by fear and concerns about self-defense. What you have witnessed over the last 4 years is a channeling of the fears of immigrant caravans massed at the border, marauders coming to destroy your suburban home. The last 4 years, particularly last few weeks, can be understood as a nationwide test of the proposition of whether psychological egoism will win the day, whether we will have a country that has for 4 long days, we were wondering what the verdict would be about whether we would have a country that was going to live under this rubric of psychological egoism. So to kind of move towards a conclusion, this ego-centered white grievance mixed with a profound rejection of compassion, a stoic indifference to the pain of others, this has long been part of our politics, often a politics that's shaped by compassion, whether it's George Herbert Walker Bush calling after 4 years of Ronald Reagan, who he served under, for a kinder, gentler nation, which prompted Nancy Reagan to say, kinder and gentler than whom? It's also the politics of compassion that explains Bill Clinton and his phrase, much caricatured, relentlessly caricatured by the right, I feel your pain. It's also evident in the kind of callous disregard for pain that our current president has, and also caricatured by the left in many ways. So for instance, when the First Lady was on her way to visit the child detention center in Texas, wearing a jacket that said, "I really don't care, do you?" Now, all of these are just small phrases, but they stand in. You might say they're major chapters in the ongoing politics of pain. Let me skip past this. What I wanted to end with is to talk a little bit about who's pain mattering being part of a larger microcosm in healthcare, but also in professionalism, pointing you to an article that came out a number of years ago in the Proceedings of the National Academy of Science, which found that University of Virginia students and residents harbored mistaken beliefs about Black bodies and their capacity to experience pain because of thicker skins, completely fatuous ideas about Black people having thicker skins or blood coagulating at different rates. And the speculation is that these views could translate into differences in pain care. Or I'm reminded a couple of years ago in the high point of the opioid crisis when a reporter, having learned about the that African Americans, Latinos were often undertreated for pain, asked me whether therefore Blacks were not protected by being denied access to pain relief. And I said to him that this is a perverse sort of notion of beneficial discrimination. That is to say, you should read the pain of people of color through the lens of white distress. So let me end with some reflections on whose pain matters and come back to the question of whose breathing matters. The fundamental, you might say, I have not talked about Black grievance. I've talked about white grievance. And of course, I should be careful not to stereotype all whites as having similar kinds of grievances to one another and all Blacks, African Americans as having similar grievances. I'm really talking about the political discourse and how it represents these kinds of complaints. The fundamental grievance of Black Lives Matter, from an ethical standpoint, is put simply and very, very differently than the white grievance story. It's rooted in an awareness of a gap between the values articulated in policing around the country, that is, to serve, to protect with courage, and to serve with compassion. This comes to you from the Minneapolis Police Department where George Floyd was killed, and the reality experienced by Black men and women, and the response to real harms inflicted. So the point here is that what motivates, the ethical stance that motivates Black grievance is the idea that these claims ring hollow, that as a matter of ethics, this grievance is righteous, and it's simply asking law enforcement officials to live up to the standards that they themselves have articulated. What kind of courage was this to kneel and to kill George Floyd? Who was being protected from whom? The stance of marchers lays out a grievance about how articulated principles fall apart in everyday encounters, in everyday relations, with those who were entrusted by the state with the power to protect. The harms and the inability of a criminal justice system to hold police accountable for those harms. These are the kinds of motivating factors. They're profoundly moral and deeply based on particular kinds of principles. And these are the kinds of outrages that also, these systemic failures keep recurring. So 2 weeks ago, Walter White Jr., a 27-year-old man with bipolar disorder in Philadelphia, after his family called an ambulance for a mental health episode, shot by police who apparently did not have tasers. The ethical argument here is very simple, and it was articulated long ago by Martin Luther King, right? To challenge a nation to live up to the true meaning of its creed and to hold truths that are self-evident and to translate those into lived realities, that all men are created equal. So very different ethical standpoint for the kinds of grievances that we see today. I'll conclude by saying a little bit then about where next. I've given you a complex and varied and in some ways depressingly long list of the revealed inequalities in this, our pandemic year. I'd say the challenges in the months ahead are numerous. Some of them are easy and simple relative to the others. One of the challenges is to live up to the very standards that are articulated in this image. What does freedom mean? Unity, peace. What does it mean for Black lives to matter? And what, after all, is justice? And how do you build a society and a set of systems premised on these principles? The challenge in the months ahead will be many because, after all, it took decades for this system to be constructed, one might argue even centuries. But some of the steps ahead are relatively straightforward. A public health system, I could end there, but a public health system that prioritizes N95 masks for all essential workers. Social support system for the mentally ill, such that they are not put immediately in harm's way by police, but also reform of the policing system to live up to articulated ethics, an ethic of serving with compassion, an end to a criminal justice system premised, and I'm referring here to the detention system, on cruelty as a deterrent. And then, I don't think it's at all a coincidence that we have an incoming president who ran on a simple word, decency, as a self-evident relational idea. What would it mean to build a new society, to create public policy with this commitment in mind, rather than the commitment to cruelty and to inflicted pain? And ultimately, I think this is a larger ongoing challenge, is how do we move past the politics of narcissistic white grievance to a system dedicated to making lives, specifically Black lives, matter? Thank you very much for your attention, and I look forward to chatting as we move ahead. Thanks.
Thank you, Keith. I wish you could hear right now a room full of hundreds of people clapping, but know that you have hundreds of people sitting in individual rooms clapping, I am sure, just like I was doing a moment ago. So thank you for spending that time and raising such important and thought-provoking comments. So I am going to spend the next only about 15 minutes or so that we have for questions, drawing from a number of questions we received in advance, as well as several of the questions coming through now. Again, I apologize in advance to those who are here whose questions we don't get to. It really is simply a matter of time on our end. So let me start with something that I think really jumps off from a number of points that you ended with, and it's a question about healing fundamentally. The question is, how do we reconcile and heal the damaged relationships between racial and ethnic groups in the US? What are some first steps we need to take?
Well, these are all profound and difficult questions. I think much of it depends on where you live. I think in some ways, the best place to start these conversations is locally, relationally, and in terms of how we interact with one another. In other words, when President Obama was first running for office, he said that we tend in America to think of the race as spectacle. And our public conversations about race are rarely, I should say, oriented towards anything other than spectacle. And the spectacular nature of race relations don't often lend themselves to a discourse and practices of healing. Well, that said, when you look at the marches that around Black Lives Matter, particularly this year, what was stunning and eye-opening for every American is to see the diversity of faces, the diversity of ages, and the cross-racial commitment to the idea that what happened to George Floyd and what's happening elsewhere ought not to be the case. So in some ways, I see Black Lives Matter as the beginning point of precisely the kind of cross-racial healing that is necessary, despite the effort to caricature it as violent, extremist, and so on.
Thank you. And I think a more specific version of that question, or maybe a more concrete question, again, in a similar vein, which is, what are the first steps healthcare providers specifically can take to improve social justice and pain management for racial and ethnic minorities?
So one of the things I find frustrating and difficult about pain as a topic in healthcare is how frightfully little education healthcare practitioners have about pain, about the difficulties of actually understanding, doing intersubjective understanding. So, you know, I think that in the midst of the current opioid crisis, that has fed a sense that overindulgence, overtreatment is itself an evil. And so there's been a great deal of substituted judgment on the part of physicians and also public policymakers to say, you know, the less pain care, the better. I think it's up to physicians to continue to advocate for compassion and advocate for relief, but also to, you know, really not allow the concerns, which are legitimate, but concerns about opioid dependency in one group to shadow and to inform their care or their lack of care for others. And I think African Americans, racial minorities, Latinos have been historically undertreated in the medical realm. And I think that, you know, it's important that healthcare providers compensate, really. I mean, in much the same way that I say that we ought to understand that multi-generational households and people who in essential work are adversely affected by COVID-19, and as a result ought to be given special consideration with regard to PPE, but ultimately vaccines. I also would say that, you know, given the historical undertreatment and marginalization of people of color, that, you know, practitioners owe it to themselves and also to others to overcompensate in terms of understanding the nature of pain.
Thank you. And you just mentioned vaccines, which I think transitions well to another question we got, asking, how do you see a vaccine being received among racially marginalized populations?
So this gets back to my point about how it's very hard to generalize about any population, Black, white, Latino, and in some ways I've kind of indulged those stereotypes. That said, it's clear that skepticism and mistrust about a system that has not served people adequately will shadow into and carry into skepticism about the vaccines, especially given the misinformation that exists around vaccines and their dangers. I have a feeling that this vaccine will be a little different because of the nature of the crisis and the nature of the pain that's afflicted African Americans. I think, though, that one strategy is to have the PPE discussion first. In other words, and to have some of these discussions in anticipation of the arrival of a vaccine. That is to talk openly about prioritization, about those who have been adversely affected to a larger degree, and what ought to happen, so that it's not simply that we have a vaccine and we are now going to be distributing it. But the other thing is to kind of just really pay attention less to questions of race and more to questions of the situatedness of minorities, as in multi-generational households, living in dense communities where social distancing is difficult, working in essential jobs, which put you at greater risk. When you layer all of those into consideration as to who should be prioritized in vaccines, you're effectively addressing the issues that we have just discussed.
Wonderful, thank you. Now, here's a question which I think might have particular relevance as we're all preparing for at least virtual get-togethers with our family in the coming weeks. And I think ties into many of the things you've been speaking about. That's how can we deal with the unwillingness of some people to accept and adapt to a new situation morally and ethically because they do not want to think critically about a new problem, but would rather dismiss it as non-existent?
Yeah, that's an interesting, that kind of, that's a very hard question, right? Sort of, it's denial a little bit, but it's also about the discomfort associated with even grappling with what in fact is a very complicated situation. And it's a situation that's changing. So, for instance, our knowledge about masks has evolved a great deal in the last 9 months, right? I mean, at first it was masks won't do very much good, and then empirically we've learned more. I guess what I'd say is that I'm not sure I have an answer to this question because it so much depends on the nature of your relationship to the person who you're trying to convince or you're trying to speak to. I was just talking to a family member just recently, and instead of saying, I don't think you should go out and hang out with friends, what I said is, I was in the grocery store and there was a guy coughing nearby, and nothing about the situation felt good to me. And so I just turned around and head the other way. But I realized that it's not just the person who is coughing that I should be concerned about. And so by telling your own story, I was also trying to communicate about my own anxieties, my own concerns, and then open up a conversation about that. So one strategy is to articulate to be open about your own uncertainties, to be open about the nature of evidence that you are weighing in guiding your actions, and then really inviting other people who are skeptics to have a conversation about that. I'm not saying that would work, but I am saying that is one among many strategies.
Thank you. I think we all very much appreciate the strategies to take in hand over the coming weeks. So another question that's come up, and I should say, actually, we're running to the end of time, so I'll try and limit this to probably just about 2 more questions to be respectful of your time and the time of everyone who just joined us this evening. But you mentioned that perhaps ethics really is central to what's been going on with our current pandemic year, but perhaps not explicit. And I'm wondering, has it been explicit? And if not, is there a way to make it more explicit and a value to being explicit about when we are making ethical choices and having conversations about ethical issues and having ethics at the table, frankly?
Mm-hmm. I think that there is value to making it as explicit in one situation or another. So take, for instance, the question of PPE and vaccines. I do think that we are coming up to a point when a conversation about fairness, I don't mean, now you could use the language of equity, And you could use the language of, you could talk about those who sacrifice and for the greater good and what is owed to them. There are complicated ways, but there is a broad conversation about what is fair that we could have in an explicit way, and we could call it ethics, right? Because it would be an ethical conversation. The challenge sometimes is if you put the ethics label on something, it actually, by putting the label on it, it makes it seem removed from the world in which we live, where if you use the language of fairness, you're effectively having an ethics conversation. And I guess what I was trying to highlight is that if you take the word ethics out, we have been having ethics conversations left and right. Some of it is a little bit more submerged than others. And then, as I said, through the lens of the last 4 years, I regard what we've been having is a kind of a funhouse mirror skewed conversation about ethics, as in, like, you know, you have a president who has an idea of loyalty, says the press, right? But what definition of loyalty this is, which is, of course, a profoundly important value. So it actually warrants a conversation about, well, what exactly is loyalty? And what does it look like? Because this isn't actually loyalty that we're witnessing here. This is something else. So I use the language of sort of psychological egoism as a different way of understanding the kind of principles that have been guiding our public discourse and public policy for the last 4 years.
Thank you. And I'll wrap up again with apologies to all those whose questions we didn't get to, with a question that is a bookend because it harkens back to the first few minutes of your talk. And this person says that in the first few minutes, you described the American healthcare system as the best in the world. The pandemic has revealed a significant lack of equity in the ability to access this healthcare system. Can a system really be considered the best if it cannot be accessed by a significant portion of the population?
So I should be very clear. I don't think maybe I was. I didn't call the U.S. healthcare system. I said the system has been called the best in the world. That is to say, there are people pre-COVID-19 who would say that we have the best healthcare system in the world. I think our healthcare system is well, I would use the word disaster, but we have created over the last, I'd say, 30 or 40 years, an impoverished, starved public health system. We've created a medical system that is entirely oriented around a set of cash and a kind of a cash nexus approach to healthcare. So much so that when COVID-19 showed up, hospitals had to stop doing the procedures that they make money for in order to, and almost like run the risk of bankruptcy in order to deal with the public health challenge. That is not my definition of the best healthcare system in the world. So there's nothing about this situation that suggests that we had the best healthcare system in the world for all the reasons that that questioner just articulated. What I was being kind of perhaps too subtle and a little ironic by saying it was called that, but now we see that it not only isn't that, it wasn't that in the first place.
Thank you. And thank you again for a fascinating lecture, and to everyone who's joined us this evening. As a reminder, we will have the video recording posted and available for all of you to review, and also for those who couldn't make it. So again, a virtual round of applause for you, Professor Welu, and thank you to everyone who's joined us this evening. Have a great night.